Greetings and welcome to this video on metronidazole. We'll discuss the big picture, the commonly used antibiotic for gut infections, cover anaerobic infections. You know the basics, and before describing, you must know all these things to give a adequate treatment coverage with a metronidazole drug. So let's get started. Metronidazole is a nitroimidazole antibiotic. Nitroimidazole group of drug. It creates nitrogen bubbles inside this organism so that it bursts the mitochondrial area and creates toxicity. So it is a gold standard anti-anaerobic drug. So available as both oral and IV preparation. Excellent tissue penetration. It acts intracellularly, so it has very good excellent tissue penetration. It is powerful and a targeted drug. It is stewardship friendly when used correctly. It saves cardiac arms for other tough. So it's a very good antibiotic when used in appropriate clinical setting. So it acts as a Trojan horse, enters the anaerobes, reduced by the electron transport chain in the mitochondria, then converted into toxic free radicals, which breaks the DNA strands and causes bactericidal effect and lyses the bacteria. So conceptually, it requires an anaerobic environment to be activated, be reduced. So it only acts at places where there is anaerobic environment. So it is concentration dependent killing and not time dependent killing. So more the concentration, more the drug. So main thing that it is, the drug itself is converted into toxic free radicals, which breaks the DNA strands and creates bactericidal environments in the bacteria. Spectrum of activity only anaerobes, that is Bacteria fragilis, Clostridium difficile, Bacterium, Primipilla, and Coccus. Only these organisms. Exceptions are like maybe amoebiasis, you can use it. Otherwise, for bacteria, only these. So if the organism is aerobic, metronidazole is completely useless. This is one key takeaway point that you must need to take away from this video. So why it is preferred over clindamycin is because metronidazole has better anaerobic coverage. The clindamycin it has a variable anaerobic coverage and also there is more resistance. So above the diaphragm, we give clindamycin drug and below the diaphragm, we try to go to metronidazole group. So Clostridium difficile infection is lower with metronidazole and higher with clindamycin. Also, the resistance are rare with metronidazole. It is common in clindamycin, especially with bacterial strains. Colitis risk, there is toxin-mediated colitis risk for clindamycin, but rather there is none for metronidazole. Contraindications, there is severe liver disease. When there is severe liver disease, there is significant risk of accumulation and increased risk of neurotoxicity, hence not given in severe liver disease. It can be used with caution in prolonged therapy for more than 2 weeks, even in patients without cirrhosis. So use caution in prolonged therapy. Don't use it for more than 2 weeks. Drug interaction, metronidazole mainly has psychotic reaction. Metronidazole plus disulfiram can lead to acute psychosis, so it's contraindicated. Disulfiram useless in the last 2 weeks is contraindicated. So drugs that can cause disulfiram-like reactions, one of the main important drug is the metronidazole. Alcohol, again, there is disulfiram-like reaction. There will be severe flushing, nausea, vomiting, throbbing headache, and tachycardia with metronidazole. So avoid alcohol during therapy. Just 48 to 72 hours after the last dose. Avoid metronidazole or alcohol. So either take one, don't take both, because you will learn the disulfiram-like reaction. Cytochrome interactions, like it can moderate with cytochrome 2C9 inhibition and possible 3A4 inhibition also. So it inhibits warfarin metabolism. There is high warfarin effect and high INR. So monitor INR closely during uh, treatment with metronidazole. So try to avoid metronidazole therapy in patients with post-aortic valve replacement, where you give warfarin, or in patients with Aplar syndrome, where you give warfarin. In all these cases, in the patients with loose stools or anaerobic infections, try to avoid this group of drugs. So common side effects again are nausea, diarrhea, and main metallic taste. That is just dyspepsia is very common with metronidazole. So other important side effects are metronidazole induced encephalopathy. It can lead to seizure, it can lead to peripheral neuropathy with tingling and numbness. Very important complication is peripheral neuropathy, and it can rarely cause asymptomatic meningitis also. So there are a lot of neurological side effects like seizure, neuropathy, and asymptomatic meningitis, especially when there is prolonged use for more than 2 3 weeks and when there is hepatic dysfunction. So MRI changes and symptoms are usually reversible after stopping the drug. Other rare but serious effects are like Steven-Johnson syndrome, toxic epidermal necrolysis, Rett syndrome, and AGEP. So again, systemic effects can itself lead to pancreatitis, can itself lead to hepatitis, it can lead to hemolytic uremic syndrome, blood fever, neutropenia, and so on, which are also one of the most toxic drugs because of its mitochondrial toxic free radical production. It can lead to all these adverse side effects that can be explained with the mechanism of its action. General principles, it is generally safe and effective, but you must ask one simple question. Do I truly need an annual coverage? So it is not needed for community acquired pneumonia because aspiration is rare in community acquired pneumonia. And also for most urinary tract infections, don't go for annual coverage. And for uncomplicated cellulitis such as staph and streptococcus dominant cellulitis, don't go for annual coverage. So avoid redundant coverage, like do not routinely add metronidazole, meropenem, ampicillin, sulfate because all these drug itself has anaerobic coverage. So Sulfate itself can cover anaerobes, meropenem itself can cover anaerobes, and ampicillin sulfactam itself can cover anaerobes. So metronidazole just adds Clostridium difficile coverage, except that other than these three drugs that does not cover against Clostridium difficile, metronidazole adds against Clostridium difficile. That's the only added advantage. It is mainly used, especially when there is anaerobic infection is uncertain, reduced dosing, and it can be used empirically. These are stewardship wells when to use it appropriately and when to not use it inappropriately. So, reduces neurotoxicities while maintaining efficacy. Clinical uses mainly for intra-abdominal infections such as peritonitis or abscesses, mainly used cases. In CNS abscess, there is excellent tissue filtration, so it can be used. Gynecological, like pelvic inflammatory disease, bacterial vaginosis, on all these cases, this becomes a drug of choice. Respiratory aspiration pneumonia, if it is severe, you can use, but always respiratory infections above the diaphragm. Contamination is other than metronidazole. Again, for skin and soft tissue infection, especially for diaphragm, which is ischemic and post-cutting, you can go with this. And the combination with celluloid and metronidazole is very good choice for these kind of infections. So diabetic, when there is ischemic and foul smelling, suspicion of anaerobes are there, so can add metronidazole. So whenever you smell a wound with foul smell, then you must need to suspect an anaerobic infection, and you can add metronidazole group of that. For Clostridium difficile, it's inferior to oral vancomycin or Fidaxomicin for primary treatment. So when it is used as an add-on IV in severe or terminal disease only, and if the patient cannot take oral medicines. So it is helpful in ELS. It reaches colon via the blood and also in gastroparesis. So it can be help in Clostridium difficile infection. So even IV route of metronidazole can reach the ileum, and when the patient is having gastroparesis also, you can reach the ileum through the IV route. So it can be used as an IV agent when only vancomycin or vancomycin can be used. Traditional dosing is 500 milligram Q8 hourly, that is 3 times a day dosing. The equivalent to most infection is 5 milligram 12 hourly. Not used to reduce dose for CNS infection or Clostridium. Only for other infections you can use reduced dosing. Just in renal failure, no adjustment in hepatic failure, so mainly in child C classification, you can reduce the dose by 50%. In case of obesity, there is no need to increase the dose more than Q8 hourly dose. In case of ECMO also, it is unlikely to affect the drug dosage. Pharmacologically, it is a small molecule with 117 grams per micromolar and a very slightly lipophilic, not too much. Also, 100% oral availability, you can switch to oral as soon as possible. Distribution, so it is protein bound, lesser protein bound, and only protein bound with distribution to total body weight only 0.7 liter per kg. It has excellent penetration into the axis cavities, CNS, blood-brain barrier, peritoneal fluid, and liver. So these are very good, really active in brain access and intra-abdominal sepsis. Metabolism is hepatic metabolism creates 5 metabolites. So hydroxymetabolase is 50% as active as parent drug. This explains prolonged effect and the need for dose reduction in severe liver disease. So this is very important to understand. During impaired hepatic metabolism, accumulation of toxic metabolites are there, can lead to prolonged effect and even later neurotoxicity also. So elimination, it's 20% excreted unchanged in the urine. Majority is excreted as metabolites. Urine may turn dark or reddish during therapy with metronidazole. The half parent drug is almost 8 hours. The active rate is almost 10 hours. So it's supposed to give 8 early or 12 early dosing. So it's mainly 20% excreted in the urine unchanged. Majority are excreted as metabolites. There are 5 different metabolites of metronidazole as discussed previously. It's not effective for aerobic gram negatives. No, completely not effective, and avoid prolonged therapy for more than 2 3 weeks unless necessary. In case of neural symptoms, stop the drug immediately. In renal failure, you can safely use this drug. In case of pregnancy, also it is considered safe, especially in the first trimester. You can use it, metronidazole, when it's completely safe. So using metronidazole just in case of coverage, it's not indicated. Adding it to carbapenem sulfate, it is not recommended because it itself has anaerobic coverage. Ignoring rare diseases and giving metronidazole is again a big blunder. Continuing the drug despite new neuropathy, it is also a big blunder. Treating pneumonia with metronidazole only is also a big blunder. So I learned a lot in this video, and the only thing that need to take home is it is the best anti-anaerobic drug available. But be smart. Use only when anaerobics are mattering to you in the clinical setting. So dose is thoughtfully given. You either give dose early or eat early based on the clinical setting, and always watch for neurotoxicity, especially in liver dysfunction cases. So if you learned a lot in this video on metronidazole, we'll continue this series on antibiotics with a few lucky videos. If you are not new to this channel, do check out the playlist on these antibiotics that we will give in the link below. You can access it. If you like this video, do like and subscribe. This is Medicine Beyond Harrison's. Thank you for watching.